Hi, my name is Katie Campbell. I'm a postdoctoral fellow in the lab of Tony Ribas at the University of California in Los Angeles. I'm really excited to be here and share some of the methodologies that we've been using to both semi-automate and straightly automate approaches for digital pathology in the context of clinical melanoma biopsies in correlative clinical trial studies. These are my disclosures unrelated to what I'll be discussing today. As we organize these sequencing studies, it's become pretty much routine to perform whole exome sequencing and bulk RNA sequencing on biopsies that are collected in the context of clinical trials to better understand the mechanisms of the drugs involved. However, over the course of this workflow, I don't think it's unobvious to state that there are realistic challenges and decisions that have to be made in order to best utilize these samples, considering that patients are going through this experience and it allows us to pursue the scientific questions of interest. So as we organized the collection of all these specimens and started to make these decisions, we really had to think about patient enrollment, the number of patients, the number of specimens, the statistical power related to addressing certain questions, but really how to prioritize the tissue. Given realistic limitations, we had to work in the context of FFPE preservation, which has its own limitations. And so we had to subsequently make decisions, in addition to the bulk whole exome and RNA sequencing, how to best leverage this information, best leverage these tissues to maximize the number of questions and answers available. And one of the things to really consider is the amount of time involved with each of those assays, as well as the expertise. So in the context of immuno-oncology and immune checkpoint blockade, we're thinking a lot about where T cells are, where are they in relation to the tumor, which relies on some sort of spatial query of the tissues at hand. This allowed us to work directly with the dermatopathologists to understand what kind of observations they were making in the tissues and how we could automate or reduce the amount of time associated with the parallelized processing of hundreds of specimens. So in the context of 3 clinical trials, working with the Southwest Oncology Group, we started exploring what was the basic information we needed in order to explore T cell infiltration. To that end, for each specimen, as we were making cuts to perform bulk nucleic acid extraction, we were also cutting slides at the same time, performing staining by H&E for histopathology assessment, S100 for melanoma cell markers in order to understand where the tumor was and where the boundaries of those tumors were, as well as an individual staining for CD8 to measure potential T cell infiltration. We had the expertise of a very talented dermatopathologist go through and manually review each of these stained slides, and using the QPath open source software, he was able to annotate the tumor bed and the boundary. The tumor bed in the central image is shown in red, the boundary in orange. And he, as well as a fellow, were able to do this across hundreds of specimens in the context of these clinical trials. Fortunately, by leveraging QPath's technology, we were able to automate the quantification of the CD8 T cell density both in the tumor and in the boundary. And we were able to automate this processing across all of the slides at one time. And so this allowed us to prioritize the pathologist's time in the context of the annotation of the specimens, but automate or subsidize that time association with the actual cell counting in order to get more accurate quantitations involved. So to really demonstrate the benefit of even optimizing the automation of a subset of this workflow, on the left I show a consort diagram of tissue collection in association with SWOG 1616, which is a phase 2 randomized study in PD-1 refractory melanoma, exploring the combination of nivolumab and ipilimumab versus ipilimumab alone in PD-1 refractory melanoma. And we had the hypothesis of this trial that ipilimumab can reverse primary resistance to nivolumab by facilitating CD8 T-cell infiltration. This was really kind of a collective result of a lot of multidisciplinary minds coming together to say, how can we best utilize these tissues, and how can we appropriately address the mechanism of the drugs involved? And so all that to say, the automated processing of hundreds and hundreds of specimens really comes down to this simple box plot on the right, showing that in the red box plots show the CD8 densities at baseline, the blue at time of on therapy biopsies, and we can start to see patterns associated with CD8 positive T-cell infiltration or increased quantities over the course of therapy, both in the tumor and the other indicates the boundary or surrounding the tumor. Bringing all of this together, it's really kind of a lessons learned, as well as how can we continue to optimize these processes and the rigor in translational study. It allows us to increase the reproducibility by standardizing these workflows, both within and across studies, because we're able to leverage this technology for additional clinical trials. We can decrease the manual input by utilizing certain programs that have been optimized already, but it also increases the potential for future machine learning opportunities, giving us a well-annotated data set pathologically as well as through other molecular features involved. And so with that, I'll acknowledge my mentor and wonderful collaborators and support for my training. Thank you.